Okay, well, good evening, everyone, and I'd like to thank the organizers of this conference, including Dr. Suju, for the honor of speaking to you all. And I have the privilege of speaking about IDH mutated lower grade gliomas, which I think really is one of the most exciting stories in neuro-oncology in the last 15 or 20 years. So we're going to talk about this concept of lower grade gliomas, which I'll abbreviate LGG, and how this concept has really emerged in particular from the transformational discovery of the role of the IDH mutation, or the presence at least of the IDH mutation in gliomas about 15 years ago, and how that has contributed to the evolution of our tumor classification system from a histological one to a molecular classification system. We'll talk about the role of surgery, which most of the audience is, of course, very familiar with. We'll talk about the optimal use of radiation and chemotherapy, what they accomplish, and how they're best sequenced. We'll talk a little bit about the treatment choices when a patient's tumor has progressed following first-line treatment. And one of the more exciting topics, we'll talk about the emerging evidence for drugs that target the mutated protein that the IDH mutation produces. So I think that the clinical features of lower grade gliomas are well known to the audience. Apologies for the US-centric epidemiology here, but there's about 4,500 cases each year in the US, which is about a third as common as glioblastoma. Median age of patients is about 20 years younger than that of glioblastoma. These tumors are more common in whites than in blacks, and in males than in females. And the great majority of patients present with seizures, but more and more, perhaps at least 10% of the time, these tumors are found incidentally with a widespread availability of CT and MRI when patients get imaged because of a motor vehicle accident or nonspecific headaches or hormonal issues, etc. And the typical MRI, which I think is well known to this audience, is a T2 or flare hyperintense lesion with no or minimal contrast enhancement, and I've shown some typical examples here. So what we call a grade 2 and grade 3 glioma has really changed over the years, and I think it's important to go over this. On this slide, I've shown on the top row pictures of grade 2 and grade 3 astrocytomas, on the bottom grade 2 and grade 3 oligodendrogliomas. And you can see that with a transition from grade 2 to grade 3, we see more pleomorphism, more hypercellularity, more readily identified mitotic features, and of course the difference between astrocytomas and oligodendrogliomas, the tendency towards round cells, perinuclear clearing or perinuclear halo, and the delicate branched vasculature that we typically see in oligodendrogliomas. And prior to 2016, this light microscopy H&E really was the cornerstone of classification. And one of the reasons that's relevant is that a lot of the clinical trials I'll be discussing were initiated prior to 2016 and used this classification system that we now consider outdated. Prior to 2016, neuropathologists were allowed to call tumors oligoastrocytomas or mixed gliomas, and that was a category that really took on prominence following 1990 or so, when there was a recognition clinically that tumors with an oligodendroglial component were more likely to respond to chemotherapy than astrocytomas. So clinicians all over were hoping that their patients had an oligodendroglial component and probably put some pressure on neuropathologists. And so this new category emerged prior to 2016. So the field really shifted or got a jolt about 15 years ago with the publication of these two papers that I'm showing here. The first, this science paper that looked at a bunch of glioblastomas and did next generation sequencing and found IDH mutations in about 12% of them. The IDH mutation previously was not known to be present in gliomas. And the glioblastomas that tended to have IDH mutations were those that had developed following diagnosis of a previously lower grade glioma, and typically in younger patients. So what we used to call secondary glioblastomas, those were the ones that had IDH mutations. A few months later, this paper that appeared in the New England Journal of Medicine that looked at gliomas in general more broadly than glioblastoma, and found IDH1 or IDH2 mutations in about 75% of grade 2 and grade 3 gliomas. This led a few years later to the publication of several papers looking at multi-platform analysis of large numbers of grade 2 and grade 3 gliomas. And one of these is shown here. It's a paper by the Mayo and UCSF group. And they took, I think, a couple of hundred grade 2 and grade 3 gliomas, and they clustered them. So the first cluster, and I don't know if you can see my cursor, but the first cluster on the left were these tumors that had IDH mutation and 1p19q co-deletion. These tumors almost never had p53 mutations. They almost all had TERT promoter mutations. They sometimes had SIK and FUBP1 mutations, and they did not have ATRX mutations. And these were the tumors that under the microscope looked like oligodendrogliomas. The second group in the middle here are the tumors that had the IDH mutation but lacked 1p19q co-deletion. These tumors almost all had p53 mutations. They had ATRX mutations but didn't have TERT mutations. Those were pretty much complementary mutations. And these were tumors that, for the most part, looked like astrocytomas under the microscope. And the third and final group were those grade 2 and grade 3 tumors that were IDH wild type. Many of these had TERT promoter mutations. Some of these had EGFR mutations, NF1 mutations, PIK3CA mutations, mutations that are typically found in glioblastoma. But these were tumors that histologically were not termed glioblastomas. The group then looked at the outcome of these patients, the overall survival of these patients with these Kaplan-Meier curves. And on the top, you see the outcome according to classic histologic classification. And you can see a lot of overlap among these curves, although clearly the glioblastomas in the red on the far left do the worst. On the bottom, they clustered these patients according to the molecular subtype. Oops. And sorry about that. You get much more differentiation among these curves. The purple curve on the far right are the patients with 1p19q co-deletions, but the best outcome. Intermediate outcome was seen in this group just off to the left with IDH mutations, but not having co-deletion. This third group, with a somewhat better prognosis than the frank glioblastomas, were the glioblastomas that had IDH mutation. And in fact, the tumors that histologically were low grade, shown in the red here, but were IDH wild type, did virtually as badly as the frank IDH wild type glioblastomas. So this molecular classification really seemed to be more clinically relevant than the classic histologic classification. And so this led to some changes in the 2016 World Health Organization classification system. No longer do we see mixed gliomas or oligoastrocytomas, and you can see that IDH mutation and IDH wild type made it in here, as well as the prerequisite of having a 1p19q co-deletion to be termed an oligodendroglioma, although they did have this not otherwise specified or NOS category for patients in whom, for one reason or another, molecular testing was not able to be completed. And I think as most of you know, we can find most IDH mutations with an immunohistochemistry looking for the R132H mutation, which makes up about 90%. And there's different ways, including FISH as shown here, next generation sequencing and copy number analysis to look for 1p19q co-deletion. So that really has become standard of care in our classification system. And then in 2021, the WHO changed its classification system again. They simplified things. Remember that between 2016 until 2021, if you had an IDH mutation but still looked like a glioblastoma histologically, you were called a glioblastoma. In 2021, the absence of an IDH mutation was deemed a prerequisite to be termed a glioblastoma. And those tumors that looked like glioblastomas but had an IDH mutation were now termed grade 4 IDH mutant astrocytomas. Now, WHO 2021, or CNS5 as it's sometimes called, retains grade among astrocytomas and oligodendrogliomas, but there is a question of how much grade matters in these IDH mutant lower grade gliomas, particularly between grade 2 and grade 3. There was a study back in the 1990s where they took a lot of lower grade glioma cases and showed them to a bunch of expert neuropathologists, and the discordance rate was 33%, telling you that it's hard for neuropathologists to agree on what's grade 2 versus grade 3. And remember, the dividing line between grade 2 and grade 3 has to do with mitotic activity and whether mitotic activity is rare or more than rare, subjective criteria. Shown here, a figure from a paper from Ken Aldapi's group. They took, I think, about 500 IDH mutant lower grade gliomas, and they looked at the survival curve, as you can see on the top, by grade, and not a big difference between grade 2 and grade 3. They then classified tumors by the mitotic index, whether there were 4 or more or fewer than 4 mitoses per high-powered field, and still not much difference between those two curves. So I'm not saying grade doesn't matter at all, but the grade has become much less important when we restrict patients to those with IDH mutated tumors. And a corollary of this going forward is that it's probably reasonable in many cases to lump grade 2 and grade 3 together in clinical trials going forward. So let's talk about treatment of these IDH mutant lower grade gliomas. And of course, the first thing that comes up is surgery. We can't make a definitive diagnosis without surgery. We can't assess molecular subtype without surgery. But one of the big questions is whether a biopsy is sufficient, how much benefit there is to a resection. And unfortunately, we don't and probably will never have randomized controlled data speaking to the issue of whether and how much resection improves outcome over biopsy. What we do have are a couple of sort of parallel cohort studies. One of these, the Norwegian study, 2 different districts in Norway, one of which favored resection, one of which favored biopsy. On the right, a German study with 2 nearby centers, but one of which favored stereotaxis and one of which favored open microsurgery. And in each case, resection led to significant improvement in overall survival. How much resection is needed? This has, I think, not been definitively answered, but this was a nice paper from the UCSF group published about a year ago. They had, I think, over 700 cases of patients with grade 2 gliomas, all molecularly characterized, and some of these were from an international cohort as well. And they looked at outcome according to extent of resection, molecular subtype, and volume of residual tumor. And what they found, as you can see in this bottom panel here, is that both for progression-free survival and overall survival, it appeared that the threshold was somewhere between 75% and 80% to be able to improve the overall outcome. But not only was extent of resection important, volume of residual tumor was important, and they found that less than 5 cc's residual tumor improved the prognosis as well. So perhaps not terribly surprising results. How about radiation therapy for lower grade gliomas? Radiation has long been the standard of care for tumors that were not able to be fully managed surgically, which of course is the great majority of tumors, but relatively little data on how much radiation impacts the outcome for lower grade gliomas. We do know that about a third of grade 2 gliomas do shrink measurably with fractionated radiation. And we suspect that radiation improves survival. I think it's almost a certainty, but it really hasn't been formally proven. Nobody's done a study that forbade patients from ever getting radiation. That, of course, would not be ethical. What we do have is this old European study, a study that began in the 1980s. Some of these patients were enrolled on the basis of CT scan, and of course, there was no molecular subtyping in this study, but they took, I think, about 250 or 300 patients with grade 2 gliomas postoperatively and randomized them to either observation or early radiation therapy. And as you can see in the curve on the left, early radiation improved progression-free survival by about 2 years. Interestingly, however, the curve on the right, the overall survival between these two groups was essentially identical. And only about 2/3 of the patients who were in the no early radiation group got radiation at progression. So hard to determine how much radiation really added to overall survival from this study. With a recognition that early radiation didn't clearly improve outcome over delayed radiation, as well as the recognition, as I alluded to earlier, starting in the late 80s, early 90s, that oligodendrogliomas were often chemosensitive, there began a push to see if radiation could be delayed and what the outcome of delaying radiation and starting with chemotherapy alone would be, thereby deferring the risk of radiation neurotoxicity, which is theoretically appealing. And this process was enhanced by the development and approval of temozolomide for recurrent gliomas in the late 1990s. So we're going to go over a few randomized clinical trials, but the spoiler alert is that early chemotherapy does not seem to have been a tremendous success. So the first of these studies was a European study that took almost 500 patients with grade 2 gliomas postoperatively, stratified on the basis of 1P status, and randomized these patients to either radiation or dose-dense temozolomide for a year, and then followed them with a primary endpoint progression-free survival, but also plans to look at overall survival, quality of life, and cognitive outcome. And the progression-free survival results were published a few years ago. And what you can see, the top panel here is the IDH mutated non-codeleted tumors. So basically the grade 2 astrocytomas. And you can see that the progression-free survival with radiation, the red curve, was about 2 years better than with the temozolomide. For oligodendrogliomas, codeleted tumors shown in the middle panel, you can see the two curves are really pretty much superimposable, and the progression-free survival was about 5 years in both arms. The bottom curve we won't spend any time on. Those were the IDH wild-type tumors that really now, for the most part, would be called glioblastomas. This was a complicated German study that took grade 3 gliomas or anaplastic gliomas and randomized patients to initial radiation or initial chemotherapy with salvage of whichever initial treatment, whichever they didn't get as the initial treatment. And although the primary endpoint was the time to second progression, they did report on the time to first progression. And as you can see in the print at the bottom here, the group that got radiation had less progressive disease than the group that got chemotherapy alone. So this was a trial that also suggested there was no benefit in general to early chemotherapy. Another study was the CODEL trial, and this was a study looking at the issue of whether adding temozolomide to radiation was better than radiation therapy alone for co-deleted anaplastic oligodendroglioma. So basically, did the STUP regimen improve on radiation alone? But this trial did have a temozolomide alone arm that we'll look at. Now, this trial was stopped early because it was data that I'll show you in a little while, indicating that radiation alone is not an adequate control arm for this group. But when we look at the outcome of the temozolomide alone arm compared to the radiation temozolomide arm, you can see that the temozolomide alone arm progressed in general earlier than the radiation plus temozolomide alone arm. So putting these trials together, you see that chemotherapy alone was never superior to radiation, and in fact appeared inferior in some of these subgroups. Although admittedly, one of the things that we're trying to accomplish by deferring radiation is deferring its potentially deleterious impact on quality of life and cognitive function. And we don't have data from these studies on quality of life and cognitive outcome yet. What I'm going to do now is show you a series of studies that really confirms unequivocally that combination therapy from the get-go is best, that radiation plus chemotherapy is better than radiation and reserving chemotherapy for recurrent disease. And I'll show that we've seen this now in both grade 2 and grade 3 gliomas. First, I'll show you the results of 2 trials that were launched in the 1990s in anaplastic oligodendrogliomas. These trials both tested radiation plus PCV chemotherapy against radiation therapy alone. In the US, we gave the PCV before radiation. In Europe, the PCV was given after the radiation. This is the US study, and you can see that in co-deleted patients, although the curves really run in parallel for the first 5 or 6 years, there is a tail to the curve that significantly favors the group that got PCV in addition to radiation. And when you look at the non-co-deleted patients, because this study was done before 1p19q co-deletion was considered the sine qua non of oligodendroglioma, a much lesser impact from the addition of chemotherapy. And similar results in the European trial in the co-deleted arm, the curves run parallel for the first 6 years or so, and then a clear benefit with the addition of PCV. And this is the reason why that CODEL trial radiation therapy alone arm got nixed, and the trial was redesigned now as a radiation plus temozolomide versus radiation plus PCV trial. The next trial I'll show you is the Cattenon trial published a few years ago by Martin van den Bent and colleagues. And this was a trial that was designed and launched prior to the recognition of the IDH mutation, but took anaplastic astrocytomas, so non-co-deleted tumors, many but not all of whom had IDH mutations, and randomized them to either radiation with or without temozolomide, and the temozolomide could be either with radiation but not adjuvant, with radiation and adjuvant, or not concomitant but only adjuvant, so really a 4-arm trial. And one of the most striking things we saw from the results is that the presence of IDH mutation has an incredibly profound impact on overall outcome. The median overall survival of the IDH mutant patients was between 9 or 10 years. The IDH wild type patients had a median overall survival of only about 1.5 years. In terms of the impact of temozolomide, when you look at the IDH mutated patients, adjuvant temozolomide clearly had a major impact on overall survival. For reasons that we don't fully understand, temozolomide did not seem to do much in the IDH wild type patients. And the median overall survival in patients with an IDH mutation receiving any temozolomide here was almost 10 years. So, this is really a paradigm shift. When I started out in the field, it was felt that the median overall survival with a glioblastoma was 1 year, with anaplastic astrocytoma was maybe 2 or 2.5 years. And here you see that if you have an IDH mutation, it's really almost 10 years. And the final study confirming a benefit from the addition of chemotherapy to radiation is this RTOG study done in patients with grade 2 gliomas, randomizing patients to radiation with or without post-radiation PCV chemotherapy. And these data were reported about 7, 8 years ago in the New England Journal of Medicine. And you can see, again, even though the curves ran superimposed for the first several years, a tail to the curve that strongly favors the patients who got PCV chemotherapy in addition to radiation. Now, this trial, as were the others, were all conceived of and initiated prior to the recognition that we needed to sort patients on the basis of their IDH status. But a couple of years ago, they were able to analyze their results on the basis of molecular classification. And even though the patient numbers are small, you can see in this study, in the top row, both the oligodendrogliomas, in other words, the co-deleted tumors, and the IDH mutant but non-co-deleted tumors on the bottom, in other words, the astrocytomas, the true astrocytomas, all seem to benefit from the addition of PCV to radiation. So if we're prioritizing overall survival, radiation plus chemo beat radiation in all of these trials, both co-deleted and non-co-deleted tumors in both grade 2 and grade 3. And this was despite the fact that a majority of patients in each of these trials who were randomized to the radiation alone arm did get salvage chemotherapy at the time of progression. So RT chemo is better than radiation. Radiation is at least as good as chemo. So, by transitivity, I think we can presume that if we're prioritizing overall survival, radiation plus chemotherapy is better than a chemotherapy alone approach, at least with the agents that we're currently using. But again, the caveat that we don't have outcome data on quality of life and cognitive function. Now, there remains somewhat of a debate in the field of which chemotherapy should we be using if we're adding chemotherapy to radiation for these lower grade gliomas. Should we be using temozolomide or a nitrosourea-based regimen like PCV, which is procarbazine, CCNU, and vincristine? And I'll mention parenthetically that many of us omit the vincristine when we give PCV, since it's a multi-drug resistance substrate and probably doesn't really get into the tumor. There have been several not very good or retrospective studies that have looked at this issue and that really haven't answered this question. The CODEL trial, at least for oligodendrogliomas, should answer the question of whether temozolomide or PCV is better. Some retrospective data suggest that PCV may be better than temozolomide in oligodendroglial tumors, but of course, much more hematologic toxicity with PCV than with temozolomide. What do we do at recurrence when someone has failed radiation and first-line chemotherapy? Again, a lot of older studies that are no longer very relevant since they were done prior to the molecular classification era. Some patients respond to whichever alkylating regimen they didn't get before. The occasional patient will have stable disease if retreated with temozolomide. But this, we really don't have great treatments at recurrence with alkylating agents. As you know, a lot of excitement about bevacizumab in glioblastomas, at least initially when it came out, that has unfortunately faded somewhat. But bevacizumab has been looked at in lower grade gliomas in this TAVAREC trial, again published by Martin Vandenbend. This was a trial that took patients with the first recurrence of grade 2 or grade 3 astrocytomas. They had to have contrast-enhancing disease, and they were randomized to temozolomide plus or minus bevacizumab. And there really was no benefit from bevacizumab. It didn't even improve progression-free survival or objective radiographic response, and there was substantially more toxicity with bevacizumab. Not terribly surprising. These lower grade gliomas are not VEGF-driven tumors in general. So what are the randomized trials for newly diagnosed lower grade gliomas that are ongoing. One of them is a French study, this POLKA trial. And this is a study that's looking at the omission of radiation therapy and the use of PCV alone versus radiation PCV for co-deleted anaplastic oligodendrogliomas. So, needless to say, the group that gets PCV alone is almost certainly going to have a shorter progression-free survival. But the focus in this trial is survival without cognitive deterioration. And so we don't have the results of this trial yet. The second trial is a US NRG trial looking at protons versus photons for grade 2 and grade 3 astrocytomas, again with a primary endpoint of cognitive preservation over time. So really highlighting the importance of cognitive outcomes, which our previous studies haven't reported on yet. So finally, and as I alluded to earlier, a very exciting area, the idea that the mutant IDH protein may be a target. So we know that IDH converts isocitrate to alpha-ketoglutarate. The mutated protein converts alpha-ketoglutarate to this oncometabolite 2-hydroxyglutarate, or 2-HG. And 2-HG, is as an alpha-ketoglutarate mimic, has a lot of effects in intracellular metabolism. It blocks demethylation in histones and nucleotides, so it leads to this hypermethylated phenotype. It blocks glutamate production and NAD production, and it consumes NADPH, thereby increasing oxidative stress. Now, there was initially concern that targeting IDH in gliomas might not make sense. The IDH mutation has a favorable prognostic impact. Might be we be blocking something that's keeping these tumors growing slowly rather than quickly. We did, however, see that IDH inhibitors have shown activity in other cancers. Probably the most prominent is AML leukemia, where a couple of IDH inhibitors, most notably ivosidenib, which targets the IDH1 mutation, has been approved. So starting, probably 7 or 8 years ago, people began to look at ivosidenib in IDH mutant gliomas. And, the early results I would characterize as somewhat ambiguous. It was well tolerated. Occasionally, minor tumor shrinkage was reported, but dramatic tumor shrinkage was not seen. It never seemed to work in contrast-enhancing tumors. But in fairness, it was generally being studied in recurrent tumors and often heavily pretreated tumors. A few years ago and published last year, Ingo Mellinghoff at Sloan Kettering looked at the impact of ivosidenib and a newer drug, vorasidenib, which was specifically designed to cross the blood-brain barrier better than ivosidenib. And what they did in this study, they took patients with known IDH mutated gliomas who were going to surgery, and they wanted to see if they could block 2-HG production. In other words, was the drug getting into the tumor and having the desired metabolic effect? And you can see in the control groups, 2-HG production was high. The wild type GBMs, of course, they were not producing 2-HG because they didn't have the mutated protein. Vorasidenib at 50 milligrams a day nicely blocked 2-HG production. Lower doses didn't block it, but ivosidenib in large doses also seemed to block 2-HG production. So this was encouraging. And with vorasidenib, there was an international study launched called the Indigo trial. And this was a randomized, double-blinded, controlled study with independent radiology review for patients with confirmed IDH mutant grade 2 gliomas. And the target population were those patients who it was felt that watching and waiting rather than early use of radiation and cytotoxic chemotherapy was a reasonable approach. So patients could have either an astrocytoma or oligo, They had to be 1 to 5 years out from their last surgery, no prior radiation or chemo. They had to have measurable tumor, and they couldn't have nodular enhancing tumor. They couldn't be on steroids. They couldn't have clinical deficits or uncontrolled seizures, because again, they're really trying to pick the patients who could just be watched reasonably. And the patients were randomized 1-to-1 to vorasidenib or placebo, and they got MRIs every 3 months, and the MRIs were assessed both locally by the study team that was blinded, as well as by a blinded set of radiologists centrally. And the results were published this fall in the New England Journal of Medicine, and really striking results. You could see that progression-free survival dramatically better in the patients who got vorasidenib, a median progression-free survival of about 28 months compared to about 11 months in the placebo arm. And you can see the time to the clinicians putting patients on another therapy, what's called the time to next intervention, shown on the bottom here, even more strongly favored the vorasidenib arm. Vorasidenib still has not been approved in the US. Ivosidenib is available off-label in the US because it's approved for leukemia. And this trial has launched a lot of excitement, but also raised many, many questions. You know, vorasidenib has not been approved yet. The hope is that it will be approved in the next several months. Ivosidenib is available. Can or should we be using ivosidenib in the interim? And really, who should we be using it in? I've made the point that grade 2 tumors are biologically pretty similar to grade 2 tumors. Will these drugs have a role in grade 3 tumors? I mentioned that the overall survival improved from 11 months to 28 months with the vorasidenib. But what's the tail on the curve? If every patient benefits just by 17 months, that's not all that exciting. But if there are patients who can go 5 or 10 years before needing radiation, that would be pretty exciting, and we don't have that information yet. What if a patient has had a gross total resection? Should we start these drugs now because we know these tumors tend to grow continuously, or should we wait for recurrence? Might there be benefit to starting these drugs shortly after the patient finishes standard radiation and chemotherapy, you know, the usual oncologic approach of combining active therapies? If we use IDH blocking drugs early on and tumors become resistant to IDH drugs, will that in some way confer resistance to radiation and standard chemotherapy as well? We don't know the answer to that. We also don't know if early use of ivosidenib or vorasidenib actually is going to lead to improvement in overall survival. We don't know its effects on quality of life, cognitive outcome, or seizures yet, although these are being looked at in the trial. And finally, patients, you know, if these drugs work, you know, long-term, patients are at risk of long-term side effects. And although these drugs are tolerated quite well in general in the short term, we don't know if there are cumulative long-term side effects, particularly on fertility, which is often a major issue in these younger patients. But I think these are good problems to have. So in summary, I hope to have convinced you of the crucial nature of IDH mutational status in assessing gliomas, and that it's reasonable probably to lump grade 2 and 3 tumors together for clinical trials. We do need to stratify for oligodendroglioma status and perhaps for tumor grade as well. We can no longer include those histologically lower grade gliomas that are IDH wild type. We can't lump them in with other low grade gliomas that are IDH mutant in low grade glioma trials. We know that when patients need radiation, we should be adding chemotherapy, and we still don't know whether PCV or temozolomide is better. And it's clear that over the next years, the focus is going to be on seeing how we can maximize benefit from incorporating IDH mutant targeting strategies. So that's what I had to say, and I thank you for your attention, and I'm happy to take questions.
Asta, you can turn on your microphone. We cannot hear you. Okay.
I'm sorry. I forgot to open it. Thank you for this beautiful speech in which you shared your experience. And as you stated in your presentation, after developments in IDH mutation in astrocytic tumors, as gliomas, the neurosurgeons begin to ask whether it will if it will be a difference in treatment or management of the patients. It's an important question, and you explain in your speech this very well. Thank you. And the fact that especially low-grade gliomas are seen at younger ages, the difference of in treatments will become more important. And I saw your new drug, ivosidenib, in the internet, and it's an exciting drug. What do you think about it? You asked all my questions at the end of your speech, but I wonder about this drug. It's an exciting, and this is a necessary drug, I think, for this classification. Thank you.
Well, thank you very much. Yeah, I think we're still struggling as a field. I think some of the bigger questions are, do we start after a gross total resection? Because some of these patients, particularly with oligodendrogliomas, may go many years before a recurrence. And we all probably have one or two patients who've never recurred 10 or 20 years after resection. And, should these patients be taking a drug with unknown long-term side effects indefinitely? So I think there is some reassurance in at least seeing a little bit of tumor before throwing these drugs on board, given what we know now, but that may not be ultimately the right answer. I think to some extent how people feel about this depends on their perspective and their training. I would say in general, from my professional discussions with neuro-oncologists and some radiation oncologists, neuro-oncologists are very excited about this. We love the idea of deferring radiation because we've all seen people who've been, long-term tumor survivors, but terribly damaged by radiation. The perspective of many radiation oncologists is different. They would argue that it's a small subset of patients who have meaningful cognitive damage from radiation, and that the cognitive damage more often is due to uncontrolled tumor. Who's right and who's wrong? What percentage of patients have to have meaningful radiation-related cognitive damage before you decide you want to hold off on radiation on everyone for as long as possible? I think those are individual viewpoints. But again, the neuro-oncologists are very excited. I'm not sure the radiation oncologists are quite as excited, even though I think virtually every patient with a lower grade glioma is going to get radiation at one point or another. So the issue really is timing.
Thank you. I want to ask the other questions. Ayhan cannot ask you. Thank you for good presentation. This classification of low-grade gliomas led to difficulties in these tumors. What's the benefit of this classification for neurosurgeons? He asked.
Yeah. There are some data that it is more crucial to get a complete resection in astrocytomas than in oligodendrogliomas, as molecularly defined. Papers by Martin Vandenbend's group and by the UCSF group, the Schoen-Hervey-Jumper paper that I've shown you. But I think the general rule of maximal safe resection really, in my mind, does hold for all subtypes of gliomas, IDH mutant and IDH wild type. So
he said good and total resection is a good choice for all gliomas. Thank you, more radiotherapy. Thank you. And Kumar Padal asked, does residual tumor volume decide either to go for chemoradiation versus radiation alone? If there is a residual tumor,
Yeah,
it's different
yeah,
for chemoradio or radiation alone.
yeah. Well, when folks need radiation, you know, unless they have some terrible bone marrow problem, they're all offered chemotherapy as well. So chemoradiation is the standard when someone needs radiation. I think, you know, the other question that may be implied is, does residual tumor influence the use of timing of chemoradiation? And the answer is, you know, yes, it does. Our guidelines generally say that, you know, for patients with gross total resection of a grade 2 glioma, to hold off on radiation and chemotherapy. I think it's a little more controversial for a grade 3 glioma. And again, you know, the issue of oligodendroglioma versus astrocytoma weighs in as well, because even though all IDH mutant gliomas grow continuously, on average, oligodendrogliomas grow at a slower rate. You know, the average growth rate of an IDH mutant grade 2 astrocytoma is something like 3 or 4 millimeters a year. And for an oligo, it's, you know, it's probably half that or less than half that.
And he also asked how to manage cases with low-grade gliomas in eloquent areas.
Yeah. Well, obviously it limits what surgery can accomplish. I think so. With residual tumor, those patients are more likely to get radiation and chemotherapy. And I think that, you know, the good news is that that, you know, for the most part, although radiation has somewhat global cognitive effects, you know, particularly on concentration and short-term memory, the doses of radiation that we use now are better than they used to be. You know, we typically give no more than 54 gray, and in some cases just 50 gray in small daily fractions for grade 2 gliomas. And for grade 3 gliomas, I'd argue we probably, at least for oligos, we shouldn't go above 54 gray. And, you know, I think we rarely see, you know, long-term motor damage from radiation. We may see effects on speech long-term following radiation to language areas, but it's usually not the most profound deficit. So, you know, we're not usually making people aphasic with radiation.
Okay. And another.
Aslı, Andrew is participating from Ukraine,
Hello.
from Lviv, and
Hello.
he's a good friend of
Hello.
mine. Maybe he wants to ask his question.
Yes.
Glad to see you. Asli, please, Professor, thank you for your outstanding lecture. I'm neurosurgeon and have the question. We assess MGMT status in patients with gliomas. And what is your opinion about the value of this indicator for prognosis and treatment strategy?
Yeah. So obviously for IDH wild type tumors, it's quite important. For IDH mutated tumors, it's less important. And, you know, part of that may be because we know that 90% of IDH mutant tumors have MGMT hypermethylation. So it's harder to show that MGMT methylation status is an independent prognostic variable. Martin Vanden Bent looked at this in the Catnon trial, for example, and you know, when you control for IDH status, MGMT methylation status was not prognostic. In general, I don't assess MGMT status at diagnosis in patients with IDH mutant lower grade gliomas. But I have colleagues who do, and I think it's still an open question. And I think there was a paper just recently in Clinical Cancer Research showing that suggesting that it had prognostic value in oligodendrogliomas. So I think it's still an open question, but I think there's still no proof that it adds to IDH status.
Okay, thank you very much, and greetings from me, from my colleagues from Lviv. We are here listening to your lecture, and it's a pleasure to stay here. Thank you very much.
Thank
Thank
you,
you,
Andrew.
Hasan.
Thank you, Andrew,
Thank you. Bye.
for your contribution. Aslı, I think all the questions are completed, and I see Melike Mut.
Yes.
He's a good friend of mine, and he's a colleague of Professor David, I think, from University of Virginia. Maybe she wants to say something about the subject. Melike, are you here?
Hello, everybody. It's very nice to see you again. And thank you, David, for the excellent presentation, as usual. So we are working with Dr. Schiff here. And I think from the neurosurgical standpoint, that could be an answer to Dr. Kumar Padal, that in the eloquent areas, we are trying to remove as much as possible. That is the first thing. And for any kind of gliomas, IDH wild type or mutant, again, we are trying to resect as much as possible, as safely as possible, of course. So I think that's all I can say from the neurosurgical standpoint.
Thank you, Melike, and for your contribution. Ibol Karal, I don't know, maybe where is he from? He put some MRI images and ask something, but I don't know. Melike, can you see that from the chat part? Okay. By the way, maybe Professor Bektaş Açıkgöz. Any comments?
Thank you, Professor, for your excellent lecture. I think as neurosurgeons, our minds are more clear after listening to your lecture. Thank you very much.
Well, thank you. And we're so happy to have your colleague, Dr. Mut Aslan, here at UVA, and I'm grateful that she's helped me make this connection with all of you.
And I am also from the same university as Melike. Nice to see her. Thank you.
Oh, sorry.
Me too. So I'm seeing the MRI from the first Dr. Karal. It looks like there is let's say, recurrent IDH mutant tumor. Is that correct, Dr. Iqbal Karal?
Iqbal Karal, are you here? Would you like to ask by yourself? Okay, I cannot see him. Maybe he's not here anymore.
Yeah.
Okay. So I want to thank Professor David Schiff, and I want to thank everyone who joined us today, this evening, to Melike, to Andrew, Bektaş Açıkgöz. I want to thank all of you. Bye-bye.
Bye.
Bye, everyone. Thank you.
Thank you. Bye. Thank you.
Thank you.
Bye-bye.